Hello everyone. Thank you to the ASGE and GIE Journal for this opportunity for allowing us to present our work. I am Divyanshoo Kohli, an interventional gastroenterologist from Kansas City, and I am presenting our work on behalf of my co-authors Madhav Desai, Kevin Kennedy, and Prateek Sharma, all from Kansas City. Our study is titled Safety of Endoscopic Gastrostomy Tube Placement Compared to Radiological or Surgical Gastrostomy, Nationwide Inpatient Assessment. A gastrostomy is a commonly performed intervention. It can be performed either endoscopically, that is a percutaneous endoscopic gastrostomy or a PEG, typically performed by a gastroenterologist. A gastrostomy under fluoroscopy guidance, typically performed by an interventional radiologist, or an open gastrostomy, such as a stem gastrostomy, performed by a surgeon. The PEG placement varies based on local protocol and the discretion of the medical teams. We asked the clinical questions as to which type of procedure is more commonly performed, and more importantly, what are the outcomes in terms of efficacy and safety between these three types of interventions. On a review of the published literature, we came across mostly single-center studies which had relatively fewer patients. We hypothesized that an endoscopic gastrostomy is safer than a non-endoscopic gastrostomy. We used the nationwide readmissions database and selected inpatients who underwent a gastrostomy in 2016 and 2017 using the ICD-10 procedure codes. Notably, the ICD-10 procedure codes are more specific than the ICD-9 procedure codes and can distinguish between the different modes of gastrostomy. We evaluated 184,000 patients who underwent a gastrostomy. Of these, a majority, 154,000, underwent an IR gastrostomy, about 16,000 underwent a PEG, and about 13,000 underwent a surgical gastrostomy. The most common indications for a gastrostomy were aspiration pneumonia, followed by sepsis, failure to thrive, and foregut malignancies. The unadjusted adverse events were about 5.4% overall. Among patients who underwent a PEG, the adverse events were 5.8%, 5% for IR gastrostomies, and 9.8% for a surgical gastrostomy. The most common adverse event was malfunction of the gastrostomy tube and infection of the gastrostomy site. We assessed the comparative odds for adverse events after adjusting for age and comorbid conditions. And we compared the odds between surgical gastrostomy and a PEG, IR gastrostomy and PEG, and surgical gastrostomy versus an IR gastrostomy. Compared to a PEG, IR and surgical gastrostomy had higher odds of inpatient mortality, colon perforation, infections, discharge to a nursing facility instead of home, as well as readmissions within 30 days. The strengths of this study include a nationally representative sample, a large sample size, incorporations of hospitals across varying sizes and locations, and perhaps more importantly, the ability to control for multiple confounding variables, including comorbidities and age. There are some caveats to the interpretation of the results. One of the caveats to keep in mind is that this study was restricted to inpatients. The indications for a gastrostomy, hence, may vary as compared to outpatients. Another difference is that inpatients tend to be sicker and hence may require an IR or a surgical gastrostomy more frequently than a PEG, which is oftentimes performed as an outpatient procedure. The second caveat is that this is a retrospective study and hence a prospective analysis, blinding and randomization were not feasible. In conclusion, this study demonstrates that an endoscopic gastrostomy is associated with a lower risk of adverse events. PEG should be considered a safe method for gastrostomy among inpatients who need a long-term enteral access. Further prospective studies are needed to further elucidate some of these factors. And with that, I'd like to thank you for your attention and once again thank the GIE and ASGE for the opportunity for presenting this work.